Hello friends, in today's video lecture we'll be talking about DK versus HH. So both are acute condition of diabetes mellitus. DK stands for the diabetic ketoacidosis and HHS is hyperosmolar hyperglycemic state in diabetes. So those two are diabetic crisis. We told earlier already. So what is DK? DK is the having the component three components, that is hyperglycemia, ketosis, and acidemia. What is HHS? That is hyperglycemia, hyperosmolarity, and altered mental status. So what is common in between them? That is hyperglycemia, because both are coming from the insulin resistance and deficiency. There is more glucose in the blood, but very less glucose in the body. So the body starts lipolyzing, and from the lipolysis there is ketone bodies generated, and the ketone body gives ketosis and acidemia. In case of HHS, there is no direct relation with insulin, but in sudden state the body goes hypoglycemic, and for that for the hypovolemia, the osmolarity of the blood goes high, and there is hyperglycemia, and there is too much osmotic diuresis, and for the additive effect there is very high hyperglycemia. So HHS is more dangerous than DKA. That hyperglycemia and hyperosmolarity, altered mental status leading to coma. Are these two events occur at the same time? By definition it's not possible, because in one case you see, for the DK case you see there is acidosis, there is ketosis, but for HHS is there is hyperosmolarity because of the sudden hypovolemic condition. Do decays seen only in the type 1 diabetes mellitus and the age of less than 65 years, and HHS is only seen in type 2 diabetes mellitus and age more than 65 years? It's a big question, because as we see in the books or in the other discussion, that decay, it's a very simplified, that in type 1 diabetes mellitus and age less than 65 years old we see decay, and in type 2 DM and age more than 65 years we see HHS. So this is, we can say, we see in more than 50% population, but the reason is not the same. As you see in clinical practice, the most patients with either DK or HHS have type 2 diabetes mellitus, and many patients seen with DK are more than 65 years of age. So we cannot really say that as per age difference and having know that the condition of the diabetes, we cannot say that it DK or HHS. So in this slide it will be clarified to you, that is type you can see that DK starts in very early in type 1 diabetes mellitus, and HHS is starts in late in type 1 diabetes mellitus, but both of them goes side by side in type 2 diabetes mellitus. And HHS, as you see that HHS is not the byproduct of decay, or its decay is not leading to HHS. HHS is a sudden condition where the patient goes hypovolemic. Maybe the patient is elderly and patient cannot drink by himself or herself or water, or the patient has nobody to take care of, and the patient goes suddenly hypovolemic, and the osmolarity of the patient goes high. Mortality. So mortality in HHS, as the HHS lead to coma and drowsy and altered mental status. As you can see, the patient with HHS has the higher mortality chances, nearly around 5 to 10%, and in DK it's less than 1%. Is DK because of too little insulin, and HHS is because of too much of glucose. See, for that case, I have said earlier, the patient with DK that's in very early age. So in patient with DK, they are relatively young and they have better GFR control, so they can preserve more serum glucose. than with patient with HSS. HSS, no, I cannot say that HSS is a condition, but it's a state. It's are the symptoms. In decay, for increased osmotic diuresis, you see polyuria, polydipsia. For increased ketoacidosis, you see dyspnea. Other non-specifics are abdominal pain, nausea, and vomiting. In case of HHS, you see for increased osmotic diuresis, you see polyuria, polydipsia. For hypoglycemia, you see confusion and lethargy. For the signs, when the patient is presented to you in the hospital, you will see the constitutive signs of dehydration. For the HHS, you see the altered mental status of the patient, and for DK, you see the Kussmaul respiration. Kussmaul respiration is very important for DK because the Kussmaul respiration is the deep breathing because of the patient goes respiratory metabolic acidosis, and for that reason the patient goes very deep goes in very deep breath. That is the specific for Kussmaul respiration, and the non-specific thing is the fruity odor. For those reasons, we have to rely more on the labs. Here in this table, it's very much self explaining, and by the discussion of earlier, we can say that in DK mild you will see the plasma glucose is around 250 to 800. In DK severe we see I'm sorry guys, it's should be DKA, but it's DKS, it's written wrongly. It is 300 to 800. For HHS is 600 to 1000. For the arterial pH, you see decay, it's acidosis. So surely in the mild cases it's less than 7.30. For the severe cases less than 2.5, and in HHS it's normal. For the serum HCO3 in DKA, it's 15 to 18, because it will try to compensate with the pH, so it will go down. And for the severe cases it's less than 15. In HHS it's more normal, which means 18 to 24. For urine serum and ketones, you'll see positive in DK and HHS in negative. Anion gap, as you know that DK is a high anion gap, high anion gap metabolic acidosis. So in both cases, mild and severe, the anion gap is more than 12, and in HHS is less than 12. Serum osmolarity variable in DK and mild and severe, but in HHS that is the main thing. In serum osmolarity, which is go high, it's more than 320. Mental status normal in DK, but in HHS it's altered. What are the managements? Managements is you give IV fluid to correct the sudden state and electrolyte derangement. You look for the sodium and potassium, because along with glucose there is sodium, because the hydrogen ion is exchanged with potassium and sodium, so there is massive electrolyte derangement, and you correct for the DM1 patient, you correct with insulin. And for HHS also, to improve the receptibility, you give insulin also. And if there are other comorbid condition like AGE, UTI, pneumonia, pancreatitis, myocardial infarction, and cocaine use, in all those cases you will see already the electrolyte is deranged, and that's why it's very important to correct them also. Or else you'll see when you correct the sodium, then it will not get corrected. From there only you will understand that there are comorbids, so you have to go for that. That's all for today guys. You were watching MD Medicine. Please do like, comment, share and subscribe. Thanks for watching.